Word finding difficulty is a very common presentation. So people say, look, I looked at Mary and I couldn't remember her name for the life of me. And certainly I have a little adage which goes on, which is if you know you're forgetting, you're probably okay. Now, obviously that's not a scientific diagnostic paradigm, but for me it's quite helpful because if people know that there is a specific memory impairment, and if that is all that it is, in my experience, very often it's not dementia. Now, it could be an early manifestation of dementia, but as I said, dementia usually involves a global loss of functioning, so it involves more than just memory. Often there are behavioural and personality changes that go along with a true dementia.
The decline was really quite rapid. So in hospital, she was very confused, really very, very difficult to talk to. You couldn't get much out of her. Although having said that, there were times when you could look at her and go, yes, just for a minute she is all there. She recognised me and just for a few moments you thought, well, maybe it's not too bad.
The intensive care environment can sometimes be very noisy, light 24 hours a day, lots of voices, and there's a lack of day and night. It is very common to get disorientated because of that, especially elderly people, people in pain, people who have anxiety. From the patient's point of view, sometimes they actually have insight that they're hallucinating and that they're becoming disorientated, and of course it can be very scary for them. Also it can be dangerous for the patients in that they can pull at their lines and tubes, which of course can sustaining their lives. Occasionally for the staff it can be dangerous if people get aggressive.
Patient with delirium who then subsequently goes to the ward from the emergency department, then they are still at risk of harm in the ward, and in fact the risk of harm may be greater because the ability to observe them in the ward is probably less than it is in the emergency department. So things that we were trying to do in that situation is to make sure that they're in an area that is best observed. We'll put them in a front room right in front of the nurses' station so that if problems are starting to occur they can be picked up early.
So one of the really useful things that we did with Auntie Maud, I think, was to have a roster of family members at her bedside. And that meant that there was always someone there to hold her hand, someone there that she felt comfortable with, and for the family member to be able to calm her down and to make her feel comfortable and to let her know where she was and that everything was okay.
So sometimes we would send people home who still have a delirium, but ensuring that we're sending them home with family members or carers who are able to follow that up.
If someone has a delirium, they can recover from it quite quickly and go back to almost normal, or they can recover very slowly, or some people don't really recover fully at all. If that happens, they're on their way then to residential care. They can't manage at home any longer. And we know that delirium is a pointer towards the need for residential care, so avoiding it is very important.
I do everything in my power to prevent hospitalisation in people with dementia. So I do that because the change of environment and the stimulus of being in a really foreign and difficult and challenging environment is something that often puts these people back a long way. And often we don't regain the ground that we lose in terms of memory and orientation following a hospital admission. Now, obviously, there are some things and some cases where people must go to hospital, but an ounce of prevention makes a huge difference. So, for instance, if I have a lady who has dementia who is living in the community, I will give her carer a urine sample bottle, and if she's prone for urinary tract infections, of which many elderly women are, then that carer can get a sample for me and get it to the pathologist early so that we can treat her urinary tract infection promptly when the carer thinks that they see a deterioration in behaviour, rather than letting it get to a point of sepsis and illness such that the person needs admission and intravenous antibiotics.
I think the decline from there was really, really very, very rapid. She came home, and she probably really shouldn't have come home, because I really think it was a very, very hard job caring for her in such a debilitated state.
She's here with me all the time. All the time. When I'm sitting at the table, or when I'm going out, or something. She's around me always.